For those of you who I don't know, who don't know me, I'm Dr. Kate Lysinga. I'm one of 4 DBC doctors here. We have a new one, started today, so it's very exciting. Hopefully I'll be meeting him. We'll have to come up with some way to introduce him to everybody. But tonight we are going to be talking about pain management and the opioid epidemic. This is kind of a hot topic right now. See it all over the news. Lots of people struggling with prescription pain medication, addiction, and the side effects of those. We're losing a lot of good people to these medications and these pharmaceuticals, and the worst part about it for me is that there are options. It doesn't have to be this way. So we're going to talk a little bit about that today. We're not going to go too in depth with, as far as the addiction portion of that. That's something that needs to be handled in an inpatient center. I mean, that's a bigger topic, but I would like to talk about options for pain management, especially as they relate to this current, I guess, climate, if we're talking about medicine in general and how we're handling pain or not handling it. So that's kind of our goal for tonight. I hope to get through this in enough time to take some questions as well. If anybody has questions or wants to discuss some things, we'll hopefully have a few minutes to do that. But if you have questions throughout, feel free to raise your hand. If I'm in a good spot, I can take a question. Otherwise, we'll try to just save them for the end. Make a note for yourself so you don't forget. All right? Good to go? Cool. So I always like to start out my seminars with making sure we all are on the same page as far as defining these things that we're talking about. We all have an idea of what pain is. We've probably all experienced pain, but we have to actually understand what we're talking about if we're going to all be on the same page as far as understanding what pain is. What do we mean when we talk about that? And it's more complicated than you think when we're talking about pain. It's very subjective. It's hard to measure, if not impossible, right? And there's a lot of components to pain that we're learning about and that we're figuring out that we didn't quite understand very well before, especially related to neurology, which we're going to get into as well. The term that I was taught in school that was mostly equivalent with pain from a scientific standpoint is nociception. So that is the sensation that is associated with pain. What it is detection of noxious stimuli. I like that word, noxious, right? What it means is any stimuli to our body that our body says, this might be hurting you, right, would be considered a noxious stimuli. So that pain or that nociception should tell you if there is crushing happening, if there's burning happening, if there's, right, some of these things that puncturing of cells or any damage to the tissue should be, the nociception should tell your brain that that's happening, and that is pain usually we think of, right? Now nociception happens mostly in the acute phase of pain, okay? So we have acute pain and chronic pain. Acute pain being the more recent timeline, okay? Something happening right now or very recently, right? Chronic, we all kind of know that word, right? Chronic being lingering or long-lasting, okay? So if we're talking nociceptive pain, that's happening at the beginning, while the tissue is injured, while that is happening, right? Chronic pain, turns out, has very little to do with nociception. Isn't that odd to think about, right? So at some point, pain stops being useful at preventing injury in our bodies. At the beginning, pain is helpful to us. It's doing what it's supposed to do. It's telling us, ooh, danger, 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 right? It's warning us something's going on. Chronic pain doesn't have that same function. And we'll talk a little bit more about the difference between those two things. Chronic pain can actually become more harmful in the end, okay? So we've got nociception, we've got inflammation. We always talk about inflammation with pain, right? Because that's the chemical response to this tissue damage. So you've got your nociception up front, the actual, hey, injury is happening, something bad's going on here, something damaging to my body, and then the inflammation will set in, and it will perpetuate that pain signal, okay? It also helps us to heal, right? It keeps us from flapping around a broken arm. You know what I mean? Your arm isn't still being damaged, but if you did more to it, right, it makes us go, oh, it helps us to heal. Again, this is still in the acute phase that this pain is helpful, right? This inflammation is only helpful in the acute phase. We know that if inflammation lingers, then we got more problems, right? That's when we can have chronic pain set in because of the chronic inflammation to our body. And we're going to talk about ways that we can address that inflammation, not necessarily from a pain standpoint by just dulling the pain like some of these pharmaceuticals we're going to talk about, but actually resolution of that inflammation. That's what we're more interested in. And then you have something called neural plasticity. Okay, neural having to do with nerves or the brain. Plasticity meaning flexibility or ability to be shaped and reformed. Okay, this is a whole new area of study when it comes to neurology, because we used to think that the brain is the way that it is, the nerves are the way that they are, and that's it, end of story. But what we're learning now is that the brain actually can be very flexible, it can be very plastic. That's where that plasticity comes, okay? It's like rubber, it can bend and move, and it can rewire, and it can reshape itself. And so understanding how the brain does that rewiring is pretty critical when you're trying to understand how to cause it to rewire, especially if it's been wired towards pain. And we're going to talk a little bit about how that happens in our brain. That rewiring of the brain as a response to different patterns. A good way to think about this is learning something new, like learning how to ride a bike, right? Your brain has to think really hard at the beginning how to do it, and then after a while, right, it becomes pretty simple. And the old adage goes that you can ride a bike even if you haven't ridden a bike for a long time, right? Because those patterns have been wired into your brain. So that can be a benefit, right, if we're learning to do something new or something beneficial, but it can also be a detriment. We'll talk a little bit about that. So do we understand these three main components of pain? Now, there's a lot of more components of pain, right? There's the psychological component. There's the emotional component to pain, right? All of these things are responses to pain too, but these are the three main ones that we find we can affect really well, really conservatively, right? And these are the ones that people are using things like opioids to address. And so I'm trying to show us more about, okay, alternatives to those things. So that's why we're going to focus on these, even though we understand pain is a much bigger topic even yet than this. Does that make sense? Good with that? Okay. So we know the what. The function, we kind of touched on this because of the what, right? So we know that pain informs our body of what's going on. It protects our body from harm or from danger. And it instructs our body how to change patterns to avoid those things, right? So it informs, it protects, and it instructs. So pain can be a very good thing, especially in that short term where it's doing these functions really, really well. Now the instructive portion is where we get in trouble, right? Where our body learns these pain patterns and has a really hard time unlearning them. And that's that chronicity that we talk a lot about. So the downside of pain, right, is chronicity. It hurts. That's the main downside of pain, right? It messes things up. It depresses the immune system, it impacts mental health and cognition, it creates abnormal movement patterns. Remember this one deserves a star. We're going to talk about that later because we can affect that with what we do here. It impairs sleep, it causes hypertension, impairs sexual function. Pain does all of these things, especially when it becomes chronic. And that's really where people are running into issues with these opioid addictions, right? It's not the short-term pain that gets them. Although, I will say that how you treat your pain short-term directly affects how your pain is or does not become chronic, right? And how it is treated chronically is where we get into, you know, more of this trouble. But it really does not take very long to become addicted to these medications. So even treating acute pain, right? Even 3, 6, 8 weeks of these medications are enough for your body to become dependent on them. So if we can come up with better ways to treat acute pain, which we have lots of those too, then we will lead less to those things. But usually people who have trouble getting rid of their chronic pain are the ones that really struggle with opioids. So those are the ones that we're going to focus on tonight, that chronicity, where all of these downsides. Can you think of any other downsides of pain? I know I hit the top ones, but quality of life, right? I mean, that kind of encompasses all of these things, but that's a big one.
How does it depress the immune system?
How?
Yes.
Through that neurologic pathway. So the body doesn't talk to itself very well because pain kind of gums it all up. And you use up a lot of resources to keep yourself in pain too, those chemicals that are involved. Then we start talking a little bit about adrenal fatigue, if you're familiar with that term, right? Chronic pain can cause adrenal fatigue, and that chronic stress on the body can depress our immune system. We know stress is one of the big ones, depressing immune system. So
it can get in the way of mobility.
Totally gets in the way of mobility. And that's one of the things that, ironically, we use to treat chronic pain, is increasing mobility and stability.
Right, and it can affect relationships too.
Big time, huge. And that's that emotional, psychosocial, that sort of part of pain, big time. Especially if we're talking about addiction. Talk about a wedge in between people. Talk about, hard time communicating. I mean, it jams up relationships like crazy. Very, very difficult. So that's one of those things that we definitely have to consider as well. So lots of downsides to chronic pain. Interesting article from this journal, Pain Medicine, way back in 2011, okay? They were starting to look at this phenomenon of pain, chronic pain as a neurologic disease, okay? And that's really an interesting and a different way to look at chronic pain. Usually we think about, okay, reduce the inflammation, if you stop that signaling, then the pain should go away, right? Well, we know in all practicality that's not how it works. We wouldn't have chronic pain syndrome or fibromyalgia or all these other chronic conditions if it was that simple. So that's one of the things that we're going to look at, mostly because this practice, because we're chiropractors, we know that we can directly affect those neurological pathways. And if we can affect those, right, then we can definitely affect chronic pain. And we'll talk a little more about that here coming up. One of the interesting researchers that I happened to hear at a recent convention conference is a woman by the name of Dr. Heidi Havik. She's from New Zealand. She is she's hilarious, number one, but she's also a very brilliant researcher and a chiropractor. So she does both of those things. She's kind of straddling those worlds between neuroscientist and chiropractic. And she just had written a book trying to help all of us understand, chiropractors and non-chiropractors alike, how this neural model for pain can be helped with chiropractic. She says it really well here. I'm going to read just a few lines from this. The presence of pain itself has been shown to alter all sorts of aspects of how muscles are controlled by the brain and how they function. Put very simply, your brain can learn to function poorly and sense pain just the same way it can learn to ride a bike. We talked about that. If you skip down to the green, if this goes on for a long time, it may change the way the brain processes the reality of what is happening in and around the body. These kinds of maladaptive or bad plastic, there's that word again, right, neuroplasticity, brain changes are thought to be involved in the initiation of chronic pain conditions. That right there, these little sentences, revolutionary when we talk about our understanding of chronic pain. You hear people say, oh, we think it's neurologic pain. Well, this is the real deal. This is what's actually going on in our brains when we get that bad wiring, right, with chronic pain. And she goes on in this book to show how chiropractors can actually affect that. We're going to talk just a little bit about that in a second. Let's head back to opioids, because we want to touch on that just a little bit, just so that we all understand what we're talking about again. Opioids are pain medications. They have other uses that I've heard of, kind of off-label uses, but mostly opioids are prescribed for pain, okay? Lots of different pain conditions that opioids can be used for. Vicodin, a lot of people have heard of that one. Oxycontin or Percocet, morphine, you've heard that's been around for a while, right? Codeine, fentanyl, they are all derivatives of this poppy plant, the opium poppy plant, okay? So these kinds of, I guess, pharmaceuticals have been derived from a natural substance. And that's how it was used way at the beginning, was to kill pain, was these opioids were used for that. However, they also create lots of other side effects that to some might be desirable, right? But are ultimately not so good for us, right? That's how opium was used in the past as a drug. People wanted to get high, right? People wanted to dull their pain and their senses. And it is very addictive. It's always been very addictive. And so have these medications. The interesting thing that we're facing right now is that we're learning pharmaceutical companies at the beginning of these medications did not do their homework, and they told medical professionals, they told physicians that these drugs were not addictive. And they told them that for a lot longer than they should have, and they knew better. That's what you're going to see kind of coming out now, is that these pharmaceutical companies knew for a while that these things were not going well, and they just kept their mouths shut because they were making a lot of money. And so now we have this opioid crisis, right? We've got doctors that are overprescribing these medications for long periods of time. They have not been well regulated until now. Obviously, those things are changing, those prescriptions, how we are prescribing these things. I have several people in the medical field who are in administration. They're telling me about all their new protocols they have to go through, and they're trying to make it harder for people to get these medications. But it's kind of like the cat's out of the bag, folks. Like, you know, this problem is already here. And just reducing the number of prescriptions is not going to get to the root of the problem. The root of the problem has a lot more to do with how we value pain management and how we approach it as medical professionals, and the time and the effort that we're willing to put into it. So this opioid crisis that we're in now, in the Midwest alone, opioid prescriptions are up 70% July 16 to September 17. 70%. Just in the Midwest. Isn't that insanity? I heard a stat, somebody said that there's enough prescription opioids for everybody in the United States to have a bottle. Enough of it has been prescribed for all of us. Everybody, every person in the population. It's crazy. That is so much. And the thing is, you know, it does have all of these side effects, right? We have liver failure. We have all of these emotional, psychological problems that come along with side effects to these. You can't really function the way that you're supposed to. Cognition is down. More infections, slows down healing, right? These opioids actually hurt us. They're not helpful. And they certainly don't address the root cause. So all of these aside, addiction and overdose is the bigger problem, right? And the stigmas that go along with these things are pretty sad too. You know, a lot of folks, they think about drug addicts, people who are overdosing, they think, oh, these people are getting these drugs illegally. You know, these people are taking too much of this medication. They're taking more than they're prescribed to take. No, that's not what's happening. These are legally prescribed. Like 40% of opioid deaths are from prescriptions, not illegal drugs. And you can overdose even if you don't take more than you normally take. Even just taking these medicines at a different time than you normally take them can cause you to overdose. That's how crazy this stuff is. It's a big deal. Up to 25% of people that are given opioids get addicted. And that's anybody given them, right? This isn't necessarily people who, this isn't people who are taking them even for a long time. Anybody given these things, 25%, 1 in 4. So 40% from these prescriptions. That's the biggest statistic to remember, I think, in this. That's where the crisis comes from, right? Yes, there is a problem with these medications leading to other illegal drugs. I agree with that, right? People start somewhere, and they start with these prescription pain medicines, and then they can't get their hands on them anymore because their doctor says, oh, you can't take this, you're getting addicted, and doesn't give them any better options. Okay? No better options. Just stop taking them. Well, if you're a drug addict, good luck with that, right? If you have this chronic pain and your brain is wired to tell you you have this pain, then yeah, that's where you're stuck, okay? And then they find their own way, right? They find other illegal drugs to take to manage their pain. And that's even more deaths associated with that. So again, the focus tonight is that there are options. We just need to work to make them more available. We need better pain management. And there really are a lot of options. Tons of options for pain management. Unfortunately, opioids aren't the only bad ones, right? Even our NSAIDs, our acetaminophen, our muscle relaxers, all of those have negative side effects too. And those are usually what people either fall back on or go to first. There are a lot of barriers to conservative chronic pain management, which is, I think, probably the biggest thing that we need to think about and talk about, that we aren't providing these options for people. Whether it's because something like seeing your chiropractor, right, or seeing a chiropractor takes more time and effort than taking a pill every day. Or it takes more time and effort for a primary care physician to say, you know what, I'm not going to prescribe this medication to you because I'm worried that you're going to get addicted. So instead, I'm going to refer you to a physical therapist. I'm going to refer you to your chiropractor. I'm going to refer you X, Y, and Z, right? All of these proven, they're proven to work for pain, and we just don't refer. A big reason for that? Insurance companies, right? We can't get reimbursed for it. So people can pay nothing for their Vicodin, or they can pay $50 an adjustment, right, out of pocket. What do you think people are going to choose? A lot of times they're going to choose the pill. So this is a big picture thing too. We got to figure out how to make these conservative pain management options less expensive, more accessible, right? We need to have awareness of alternatives. Like I had mentioned before, people aren't even told that they have options. They're just handed a prescription and said, do this. So these barriers to conservative chronic pain management, I think, definitely add to this pain management problem. And it's a very philosophical conversation. It has very wide-reaching implications, I guess, but I think it's time for people like us here at DBC, chiropractors, physical therapists, to really step up our game and say, hey, you know what? We can handle this stuff. We're really good at it, and we need to let the doctors in our area know. We need to let our medical systems know. We need to let people making legislation know that, hey, we can help with this. This is what we do, you know? This is our whole thing. And so if we get on that soon and get that acute pain so it doesn't go chronic, or figure out how to treat that neurologic pain pattern, then I think we're going to do a lot better than they can do with these opioid medications. So let's talk about chiropractic, because it's a capstone of what we do here at DBC. Like Dr. Havik said, it really can rewire the brain. And there's some really, really good data out there about how well we can manage this. So patients starting with care with the doctors of chiropractic have the lowest rates of opioid prescription. There you go, right? Like there should be billboards out there saying those things. It should be common knowledge, because less than 20% of people see a chiropractor. Less than 20%. But the second leading cause of visits to the doctor are back pain. Those numbers don't add up. That doesn't make sense, right? Why, if we're having all of those people headed to the doctor's office, why aren't they all getting sent right to a chiropractor? Because this is the stats that we've got to boast about, right? CDC guidelines even say spinal manipulation is the first line treatment. First line.
For back pain or for what?
For chronic pain. Isn't that crazy? First line treatment. That's where you should come first. Guess who comes to us first? Nobody. Unless they've been here before, right? They try everything else. They've been taking ibuprofen for a month. They tried muscle relaxers. They went to urgent care. They got x-rays. They did PT. It's been 6 months of pain by the time they get to us. Guess what we could do if they came to us within 6 days? If the urgent care center said, you know what? These medications, we're not going to do that until you've tried some chiropractic work. Why not?
Is CDC the Center for Disease Control?
Mm-hmm. Yeah. Yeah, and there's a lot of other guidelines that they put forth, right? Even just icing it. You know, instead of going to the ER and getting handed a muscle relaxer, what if we said, you know what? I need you to do some icing. I need you to see your chiropractor, and I need you to follow up with your primary care if you're not better in 6 weeks. Boom. Chiropractic takes care of it, right? But it requires this urgency, right? We need to get on top of things right away. I saw a statistic that if you don't have pain under control in 6 weeks to 3 months, that's when it goes chronic, right? And once it goes chronic, that's a whole nother animal, right? So if we can get on top of this right away, instead of just hoping it gets better or taking muscle relaxers or doing all this other stuff for 3 months, if we're urgently treating this acute pain, we don't have to worry about it going chronic. We also have to retrain the brain. That's what chiropractors can do. Heidi Havoc talked about that. She talked about how they did experiments showing the brain changes before and after adjustments, comparing them to sham adjustments. Even without pain as an indicator, right? This is just even non-painful people are showing these brain changes that are pretty phenomenal, just from chiropractic manipulation. Here's how that works. So you've got abnormal joint movement, okay? This is different spinal information sent to the brain, creates dysfunctional processing and integration, creates poor control of the spine and the body, leading to pain and dysfunction, leads to abnormal joint movement, leads to different, right? So this cycle is how you end up with that rewiring, right? In the brain and the central nervous system, and how that can perpetuate itself, right? That you've got this poor control of the spine, poor control of the body, which leads to more pain and dysfunction. The brain doesn't know what's going on in the body. And chiropractic has been talking about this idea for a long time. I mean, they used to talk about it way back in the day, like the spine got pinched, like physically pinched, and it was like a hose and the water couldn't flow right. I mean, that's how much they understood back then, but they weren't that far off. That's the craziest part about it. We just understand how that works now, how that brain and that neurology affects how your body understands what's going on around it and how that can lead to this pain dysfunction. So spinal adjustments here create appropriate joint movement, which create that appropriate spinal information to the brain, appropriate processing, better control of the spine and the body. And again, these studies that she did really didn't have a ton to do with pain, because she didn't want to muddy the waters with how pain worked, but they showed even in people with occasional pain that this could reduce and that this could help their brain function better. So we know that chiropractic should be that first line defense, and it's something that is non-invasive. It's conservative, it's very, very safe, and extremely effective at reducing pain, especially chronic pain. Another thing that we do here at DBC is acoustic compression. Acoustic compression has loads of studies showing how it decreases pain, especially this neurologic mediated kind, okay?
What is that?
So any pain from the nerves. So if it's the nerve is the thing that is telling your brain there is pain.
All pain from the nerves?
No, you've got those nociceptive, remember, and you've got inflammatory. So it does that too. It also decreases inflammation, but as opposed to the chemical type of pain. So you have that nociception, right?
I know what
Yeah, so that whole thing. That's why I'm just pointing out that acoustic compression can also manage the neurology side of pain. It stimulates cell growth, creates new blood flow. It does all of this by extracorporeal shock wave. So it's kind of like sound wave, but not quite. It's very, very similar. So it's also very safe, very non-invasive. We use this for all sorts of different kinds of chronic pain here at this office. Plantar fasciitis, endometriosis, gallbladder pain, old rotator cuff. I mean, it really does a beautiful job with chronic pain. Pain that people have had for years and years and years. You know, they're waiting for a joint replacement and all of a sudden they're not limping anymore. They're walking around. So acoustic compression, I mean, this is not expensive to do. It's not, you know, if more hospitals had this or more medical systems had this, or even people were referred for this more instead of these long-term use of pain medications or these surgical operations or that kind of thing, I think we would really see a decrease in this opioid, in the need for these kind of medications. So acoustic compression is a great option. DBC Fit, I just use this as an example, but any kind of physical therapy, rehab, exercises, all of these are shown as well in research to be decreasing pain, even chronic pain. We talked about the brain, how it starts these abnormal motor patterns, right? So like riding a bike, you know, that's a good motor pattern, but these abnormal ones can be really bad for us. That can cause pain. If you're actively retraining those muscles and your posture and your body to use a different motor pattern, it's different than just taking a walk, right? It's different than just riding a bike or exercising, even though that's great for the endorphin reasons, right? Actively engaging and creating new, healthier motor patterns very intentionally is what really helps, we have found, with the pain, whether that's through stretches or specific exercises. You got to make sure you're doing them quite, you know, perfectly. That kind of thing is very, very helpful. We also know that engaging our core muscles, particular to back pain, is excellent for pain relief. Because our core, right, we think about strengthening our back muscles. Actually, we need to strengthen our abdominals and our pelvic floor and our diaphragm. All of that has a lot to do with how stable our spine is and can decrease pain and also prevent injury and give you stability. So even doing something like that, not to mention endorphin comes from endogenous morphine. Okay, so it's our body is making a healthy pain manager. Isn't that crazy? That's where that comes from. And these endorphins are, anytime you exercise, you get those. That's why people get this runner's high, right? They talk about that. It's all these lovely endogenous, happy opioids that our body makes for ourselves. Nutrition is a big one. We always talk about nutrition here at DBC. A patient of mine who's very close to me was starting to have some, what she considered age-related knee pain. And starting to limp around, had trouble going up and down stairs. Relatively young person, 55, 56, active individual, not overweight. A lot of the things that you wouldn't think, you know, knees would be a problem for her. So we tried a bunch of different things, and finally she said, you know what, I'm ready to go gluten-free. I'm just gonna try it, just gonna see. Boom. Pain gone. Now, anytime she sneaks, I see her, oh, getting up the stairs. It's a little harder, right? And she knows it now. She doesn't have any of the digestive stuff from gluten. She doesn't have any other symptoms, but gosh, it inflames her joints. And when we're talking about nutrition and pain, that's what we're talking about, is inflammation. Any pro-inflammatory foods. And that's different for different people, right? We know some foods are inflammatory for everybody. Can somebody name a food that inflames every person? Sugar! Sugar's a big one. Anything else?
Caffeine.
Caffeine can be very inflammatory, I agree. Aspartame, right? Is that really a food? It kind of is. All these processed foods, right? Pretty inflammatory for us. MSG.
Is hydrogenated oils inflammatory?
Very good.
Dairy for a lot of people.
For a lot of people. Not everybody, but for a lot of people. And that's kind of what you got to figure out, right? Is, as an individual, what foods are pro-inflammatory for you? There's dairy and dairy and dairy. Correct. And that's why it's very individual, right? But removing, at least for this patient, removing gluten proved to be very anti-inflammatory, and it really affected her pain. Now think about if she had gone to her primary care physician. What do you think they would have said? Right? Take some ibuprofen. Here, take this Vicodin. I've got patients that come in here on multiple opioids, right? Multiple a day. And then their physicians they don't seem to have any idea what else to do, right? Which is why we need to have these conversations. The people need to educate themselves on their options with these things and say, you know what, no thanks. I just wanted to make sure there wasn't anything crazy dangerous going on in my joint. I think I'm going to handle this conservatively because I know that can work. That's where we want to get. We want to replenish our micronutrients. I had a very similar situation with a patient who was having very painful leg cramps almost every night. Very painful cramps. Took a lot of muscle relaxants, took a lot of painkillers for that. Guess what they were low in? Magnesium. Magnesium was super low. As soon as they got on a regular regimen of magnesium glycinate, they were good. They didn't come back either. So micronutrients, making sure we're getting enough of what we need. We need to increase our antioxidant-rich foods. These are our colors. This time of year, they're coming out. They're everywhere. They're on the side of the road. You can just pick them up. All of the colors, right? That's where our antioxidants come from. Leave the beige foods behind. Eat the colors. That will give you all of these. What do antioxidants do? Like, what does that even mean? We know it's good for us.
Squelch free radicals.
Yeah, free radicals are the guys that do damage in our body. Oxidants, right? And these antioxidants do that very thing. They get rid of them. They neutralize them. Really, really important for prevention of any kind of chronic disease. Cancer particularly, right? And we know that's another epidemic that we're dealing with, which is cancer, right? It's getting worse and worse. So increasing our antioxidants. And then healing the gut. We talk a lot about autoimmune pain. You think about arthralgias, right? And that kind of chronic pain from rheumatoid arthritis or other types of autoimmune diseases that cause that pain and that fatigue. If we can heal up a leaky gut, then a lot of times these autoimmune conditions calm down or go away on their own. I did a whole seminar on leaky gut, and it's on YouTube now. So that would be a good place to start if you're suspicious that you might have a little bit of autoimmune pain, or it's always a good one to pass along to a friend who's complaining about pain too. It's very understandable and laid out. Sometimes we throw around these terminologies and I don't even know what that means, but very clearly autoimmune has to do with the gut. So nutrition, that's that inflammatory part of pain that we can reduce. And then we have nutraceuticals. I don't like calling these things supplements. The reason is because it's not just supplementary to the diet. These things have active components to them. Things that you wouldn't necessarily get from a diet, but that actually actively reduce some of these things. I'm going to talk about 3 things specifically that I use in general very frequently. And one of them, this Omegagenics SPM Active, has a very novel understanding of inflammation associated with it. So we're going to talk about that a little bit too. In flavonoid and ultra-inflammex, let me talk first about nutraceuticals in general. What we need from a nutraceutical is it needs to be plant-derived, it needs to be highly bioavailable. Bioavailable, meaning our body can easily access and use it. A lot of nutraceuticals pass right through the GI tract. And we're going to talk about that. One of the main ones being, a lot of people talk about taking turmeric, right? Oh, I take turmeric. You know, that's the little spice, or I eat it in my food. Great, 85% of it goes through your GI tract. Shoot, it's good stuff, but you have to bind it to something in order for it to actually be bioavailable, which we're going to talk about with the nutraceuticals that we use here. It needs to be well characterized, meaning we have to define the mechanism of action. So eating a food is healthy for us, right, for a lot of reasons, but it doesn't necessarily have a well-defined mechanism of action. And a lot of supplements out there that are plant-derived or you know, just come from a food and it's just that food listed or that root listed, sometimes we don't have that defined biologic mechanism of action. We need it to be very specific. And it also has to be known to reduce the inflammation and pain, right? And we want it to have multiple ways it does that. So we're really picky here at DVC about what nutraceuticals we do and do not use, and there's really good reasons for why we do that, because we want it to be effective. So I know sometimes patients will get frustrated with me and they'll say, Dr. Kate, I already take turmeric. This is more turmeric. Why am I taking both of these things? And I say, because you got that turmeric at Costco and 85% of it is going through your gut, right? Oh, maybe that's why turmeric didn't help me the first time around. I didn't get enough of it. I wasn't actually absorbing it, right? So that's kind of part of the reasons that we might be a little picky about what type of nutraceuticals we use. Inflavonoid and ultra-inflammex are similar. They're cousins, I would say. Inflavonoid is the anti-inflammatory portion of ultra-inflammex. Ultra-inflammex also has a lot of other stuff in it. Really, really good for gut care. It's got some good nutrition with it. So I will often use this first line for my patients who have particularly gut inflammation or chronic issues with the gut, and then eventually graduate them to inflavonoid instead. But they're very similar, so we're going to talk about them similarly. It's got this CGM, I'm not going to say that. I probably could, but I would stumble. Which combines curcumin and fibers from fenugreek, which make it absorbable. Okay, so that's why we don't just take straight turmeric or curcumin here. We combine it with these things so it's more absorbable. It does have good delivery to target tissues, like the blood-brain barrier. Whoa! Not much crosses this. If you can get anti-inflammatories into the brain, that's where we know all those chronic pain pathways are made, right? If we could get directly to the brain via this very safe, very natural anti-inflammatory with no known side effects, why not, right? That's going to be huge. It's way better. They also contain xanthohumol, which is from the hops flower. Now don't worry, there's no gluten in it. It's not beer. Everyone gets all excited. Dr. Kate, can I just drink my xanthohumol? No, it's not the same. It's not bioavailable. So this is a very good blood sugar regulator and anti-inflammatory as well. Let's talk SPM active. So first I got to tell you about this guy, Dr. Charles Sirhan. Got a lot of fancy letters behind his name, a lot of credentials. He's been working on this product for 25, 28, almost 30 years, and trying to understand how inflammation really works, especially when we're talking about resolving inflammation. And when we're talking about chronic pain, right, blocking, we've done a lot of blocking of inflammation usually. Right, all of the things that we think about traditionally as anti-inflammatories are focused on blocking that inflammatory cascade. However, what Dr. Sirhan found was that that's not enough. The body actually has to come in and resolve it using these mediators. That's what the SPM stands for, specific pro-resolving mediators, in order to actually heal, right? So They're naturally produced in the tissues during the resolution phase, and they orchestrate the completion of the immune response, and this is the big part: return to homeostasis. I know that doesn't seem like a big deal, but that is a huge, huge deal that we did not understand that our immune system worked that way. And finding these things, and that we can actually make them and actually take them, right, to resolve and to help resolve that process is huge. Because we always thought that immune response was a passive process. Complicated, okay? I have a really, really easy, accessible article written about this for you today to take, because it's, again, it's a complicated idea of how we understand inflammation, but it is very revolutionary, and I think that if you understand it now, that you're going to recognize this coming up in the future. More and more things are going to be developed to help this resolution process. So if you're interested, please come and grab one of these articles. It's a quick read. I give it to a lot of patients, but it really helps you grasp this concept of resolution, because that's what you don't get from opioids. You don't ever get the resolution. It's just a Band-Aid, but it's a Band-Aid that with really, really serious consequences, right? So if we can actually get this resolution to happen, that's when we win. So there's a lot of clinical implications, a lot of studies of many very difficult to treat chronic conditions. This is a big one. We don't have a lot of options for dry eye. That is a very, very bothersome and difficult one to treat. And these SPMs have very good research showing benefits for that. So I mean, you can find pretty much, anything on this list. I think if I had my way, I personally just take this. Just because I know my body is constantly under inflammatory stress. And if I can't make those resolvins very well, then I'm predisposing myself to these issues and other chronic inflammatory states, right? So lots of clinical implications for this. Pretty impressive, and a new way to think about inflammation that I think could really do a better job than some of these other pharmaceuticals that obviously aren't working right for us. And there's lots of other pain relievers that we use here for different kinds of pain. I just listed some of them here. Literally everything on our shelf is anti-inflammatory. I could be here all night, and I'm not going to do that to you because there's still sun out there. But loads and loads of options for pain that don't cause addiction, don't do overdoses, that don't slow your healing, that don't, right? We just have to look at it differently. And really that's what it's about, right? With functional medicine, it's about looking at it differently. It's about getting to the root cause, whether that's with acoustic compression, actually breaking up scar tissue, actually bringing blood flow to an area, whether it's those SPMs, right? Actually resolving and bringing your body back to homeostasis. Whether it's finding the trigger. What if it's gluten, right? What if all your pain has to do with something you're eating and you could just stop eating that thing? That'd probably be better. So if we look at people with this functional medicine lens, if we look at pain and pain management with the functional medicine lens, I think that we're going to find ourselves in a better place as far as how we're managing pain, because we need something different. This opioid epidemic, it just can't go on like this. And in order for there to actually be resolution, right, if you think about the opioid epidemic from a functional perspective, what do we need? We need alternatives. We need to get to the root cause. So shout from the mountaintops, there are options, right? We need to be better at letting other people know, hey, you don't have to go down this route. There's other things that you can do. We need to be better about doing that ourselves, right? About not just taking the easy way out and taking a medication or a painkiller, but trying to get at the bottom of this. It's not, certainly, like I said, it's not the easy way, but I think in the long run, it's the better way. So, yeah. That's kind of what I have for you tonight. I have these lovely articles. I've got that for you as well. But I would encourage you too to really kind of think about this and digest this. And when you're thinking, when you see something on the news, when you hear somebody talk about it, remember what we talked about tonight and remember that there are options. Remember to let people know that these options exist, because that not knowing, I think, is half of the problem. If we can get at that pain early, if we can take care of it while it's in that acute phase, if we can focus on rewiring the brain, that's when we win. Questions? Comments?
You deal with fibromyalgia here, don't you?
Mm-hmm.
Because that's interesting. You know, you go to a lot of people, well, it's not real pain. It's in your head.
Well, and kind of it is, right?
Well,
I mean,
it's
kind of.
nerves,
It's
but
the nerves, yeah. There's not actual tissue damage happening. That's the weirdest part about this whole neurologic pain thing, right? But the brain has learned this pattern of pain. And wherever that comes from, right? Long-term inflammation or whatever, in order to get rid of the pain, you have to rewire the brain. And that's where I think this chiropractor, Dr. Heidi Havoc, has a lot going for her, because she's showing scientifically with research that chiropractic can actually do that for people.
What was your book called again?
The Reality Check.
The Reality Check.
Her website is very informative. A lot of really good stuff from there. Yeah, she's from New Zealand. Good luck ordering the book. The shipping is insane. I will tell you that right now. It's like $20 for the book, $20 for the shipping. But I think she has an ebook online as well.
But I've watched some of these YouTube videos of people that have fibromyalgia. 20 years, 25 years, they can't sleep at night. The pain's debilitating.
Yeah.
They just, you know,
Yep.
roll up a ball
Yep.
and sit in place.
And I've seen patients start that way here at DBC, and you know, their pain is nearly gone or gone by the time they're figure out what the cause is, you know, and they actually work on their inflammation instead of just trying to manage it. Because usually people with fibromyalgia, even opioids don't really help them, right? Because they're not actually addressing the nerves. They're not actually doing anything in the brain. They're just dulling their senses and making them sad. So, you know. Other questions? Yes?
Where does migraine pain fall on the spectrum of what you're talking about? Is it relevant?
Oh, very relevant? Oh, absolutely. Yeah. Migraines, again, are multifactorial. So some of my people have migraines from hormones. Some of my people have migraines from neck problems. Some of my people have migraines from magnesium deficiency, or, you know, the migraines can come from a lot of different places. Typically, that's on the inflammatory. Like if you were to put them in a category of pain, I'd put them in the inflammatory category, as opposed to like the nociceptive. Typically people with migraines aren't actually, their head's not actually in a vice, it just feels like it. But yeah, that's kind of where that falls, inflammatory.
Okay. How many people do you find have migraines because of a reaction to gluten?
Again, it's usually part of the puzzle. Some sort of gut or food inflammatory trigger is typically part of the puzzle. It's not always everything. A lot of my patients come in and they're like, Dr. K, I just can't figure out what it is. And I said, if it wasn't it, if it was a one thing, you would have figured it out. But it's probably multiple things. And that's where it gets really interesting and tricky and frustrating and awesome, is if you can put all those pieces together. But yeah, totally.
I'm gluten-free, but I still have chronic headaches.
Yeah, exactly. It's not everything. But I bet if you ate gluten, it'd be worse.
Maybe.
It depends, right?
Well, I've been on, I don't think it's gluten, I think it's more like dairy, actually.
Oh, yeah, totally. It's different for everybody.
I'm not dairy for sure. So.
That's the other thing that's going to happen, is we're going to start really honing in on individualized medicine instead of just giving people a pharmaceutical. Because a person who that pharmaceutical was studied on, you know, those people, typically these studies are done on white males age 40, right? That doesn't do me a ton of good personally. I'm not the same as a white male aged 40. But, you know, the way that we do science, I think we're starting to finally narrow those things down to where we appreciate those differences, and we're going to start to recognize them and actually utilize them.
One male, age 40, from India. There's a lot of tests done over there.
Totally. Other questions for me? You know, you guys can always access us via our Facebook page too. We have a Facebook page. We have a website where you can leave questions. Info@drdenbour.com is a place where you could leave questions or talk to Nature's Remedies. We have a lot of education out there because we feel it's very, very important, which is why we do these kind of things. But if you have further questions, you know, we're always happy to, within our, you know, our legal limits, answer and give advice as much as we can.
Have you found people react positively to the SPM active for migraine?
I would have to ask my colleagues. I have not used it for migraines yet. Usually my ladies with migraines, it's more of a hormone thing, and those are usually the people, for some reason, those are the ones that I've been working with. But I'll have to try it. I don't see why not. Yeah?
Is it, you never mentioned TENS for pain management.
TENS, sure.
Is it possible to overuse it?
I'm gonna say it's possible to overuse anything. However, TENS is a Band-Aid just like anything else. It has less side effects than other Band-Aids, but it's not a long-term...
It's not a root issue solver, it's a pain reliever, yeah.
Exactly. So, yeah. There's a ton of acute care pain stuff that we didn't talk about today because I was trying to focus more on the chronic. But there's loads of other stuff like that you mentioned, other pain modalities that can be helpful, at least in the short term while you're working on some of this other stuff that, you know, a lot of times they'll do that too.
Ice can help in a lot of situations, can.
Simply. It's very simple, but hey, I'm going to let you guys get out of here. Thank you so much for coming. I know I really appreciate having an audience to talk to and people to make eye contact with. So come get one of these if you want one.